And as we have people coming on, good day. As we have people coming on, you should, as you're joining, see a title slide. So if you're having any issues either hearing me or seeing the slides, feel free to just pop something in the chat and we can help you. Otherwise, we will be promptly starting. I'm Gregory Brody. I'm the program manager for community engagement at Undue Medical Debt. I'll be hosting our conversation today with Allison Sesso and Kara Murphy. One moment. And I just wanted to do a quick housekeeping before we jump in. This call is being recorded, so we'll be editing down for content and we'll be distributing after the call. As well, we will be discussing a lot of the updates on the work we're doing in DuPage County. That will include all the information on fundraising. So everything that we reference will be included in a follow-up email following this call. So reach out, but we will be connecting with you following this call with all the information that we provide on the call. And lastly, if you have any questions throughout the presentation, please just submit into the chat and we'll either feature them if they're timely in the conversation or we'll be doing a Q&A following the presentations. So with that, I just want to do a quick overview and then I will pass to our presenters. But again, we're just doing, we'll be introducing our speakers and they will be presenting on the work that we're doing in Illinois in DuPage County. And then the following half of the call will include all the questions and discussion that come from that and through that. And then we'll be concluding the call and again, providing all the information that we'll be discussing in that follow-up email. But before I pass, I will have so again, I'm Gregory Brody. I'm the program manager for community engagement, and I have the privilege of managing the partnership that we have with DuPage County with DuPage Health Coalition for almost 2 years now. So I wanted to introduce Allison Sesso, who's the president and CEO of Undue Medical Debt, who will be our first presenter, followed by Kara Murphy. She's the president of DuPage Health Coalition. And then with that, I will pass it to you, Allison. And then we'll again engage in Q&A. And please, again, put any questions you have in the chat throughout.
Great. Thank you so much, Gregory, for that introduction. And welcome everybody. Thank you for being here and for being curious and interested or already engaged in the issue of medical debt and the work that we're doing or being interested in, DuPage and its health and well-being overall. And I just want to say how much I appreciate the partnership we've built with you, Kara. So I'm excited to be here today. So just to set at the beginning, our objective here is really to share with you our efforts to relieve medical debt and to address the issue of medical debt within DuPage County. And we're here to try to, set off a fundraising campaign to raise funds specifically for getting rid of medical debt in DuPage County. We have the opportunity of getting rid of debt for about 10,000 people. And we're going to tell you about how we're going to do that and answer your questions and hope that we can engage you on that mission to do that. So without further ado, I'll explain who we are as an institution for those of you that don't know us. So we are a national nonprofit whose mission is quite simple. It is to end medical debt. We recently rebranded. We used to be known as RIP Medical Debt, but we changed our name to Undue. As you can see, it's UNDUE because we are making people's debts no longer due. The way we see our mission, it's in threefold. We first are a source of justice in an unjust healthcare finance system. And what we mean by that is that we make people's debts undue. We relieve or erase or eliminate or abolish, whatever term you prefer, although we do not like the term forgive because we don't think anyone did anything wrong. We like to use the other terms that basically erases those people's medical debts. And so that is the way that we first and foremost see our mission of ending medical debt. We also see ourselves as a solution for patient-centered healthcare providers. So these are hospitals and other healthcare providers, doctors, et cetera, that see the issue of medical debt as problematic to their patients and want to do something about that. Those are the hospitals and other entities that we work with, and we get rid of those medical debts by eliminating them and buying them off their hands for pennies on the dollar. And I'll talk about our model and how it works in detail in a bit. But then finally, and I think importantly, we see ourselves as a moral force for systemic change. What we mean by that is that we realize that what we're doing is not fundamentally solving the problem of medical debt. It is doing what we can from where we sit. We can get rid of these debts at the end of the day for individuals in this incredible, quick way, but we do not want to exist forever. We recognize that the work that we do is unique to the United States in a lot of ways. And, we couldn't be doing this work, let's say in France or Canada, where they have, different approaches to healthcare. Because of the way we finance healthcare in the United States, we have a large problem that puts a lot of expectation on individuals in terms of what they have to pay out of pocket to cover the cost of care. And it creates a barrier to care, and it creates real problems for individuals. So by the sheer existence of our institution, we see ourselves as a moral force for systemic change, but we also lean into that. And I'll talk a little bit about that. And we do work for policy changes and other ways of getting ahead of and getting to upstream causes of medical debt. So that's who we are in a nutshell. Gregory, next slide, please. So let me tell you a little bit about our model. It is one of a kind. We're the only organization that does what we do across the country, and we've built this unique approach. We were founded by former debt buyers who understood that you can buy medical debt for pennies on the dollar, which is exactly what we do. There is a market, unfortunately, for medical debt. And so we buy large portfolios, much in the way that a for-profit debt buyer would from hospitals and other healthcare entities. And what we do is we pull out all the people that qualify, which is 4 times the poverty rate or below, or if the debt is 5% or more of someone's income. And we buy those debts again for pennies on the dollar, and that's $1 on average gets rid of $100 of medical debt. So in this example, we're trying to raise $100,000 to get rid of $12.3 million of medical debt. I mean, just to put it in real terms and what we're actually trying to accomplish today with this call. So that's essentially how our model works. And I'll go next slide into a little bit more detail. And I'm sure there will probably be questions about this, but what we do is we go to healthcare providers and also secondary market entities. So these are groups that have already bought debt from the hospitals or other healthcare providers. But we've been increasingly, since 2021, really leaning into our direct relationships with hospitals and buying more and more of our debt directly from hospitals. And that is actually what we're talking about largely today as well. So again, we focus on people that are 400% of poverty or below, or the debt being 5% or more of their income. And just to qualify that, for a family of 3, that's about $100,000. That's a 400% level. We buy consumer credit data. That's a part of our costs from a third party that we've been working with for years. It's actually called FinThrive. So we buy that income data. We have a proprietary debt engine that we have built by a team of engineers. And we put that portfolio that we buy from the that we get from the hospital with that credit data, and again, analyze all those people that qualify based on the criteria. We then leverage the donations of individuals and or at times government entities, and we apply those dollars to buy those portfolios of those portfolio that includes all the individuals who qualify, which, by the way, is usually 90% of the overall file. We use, again, the industry rate, which is, again, on average $1, getting rid of $100 of medical debt. And once the debt is purchased, we never, ever collect on it. We abolish it. We send people letters. They don't have to fill out any kind of application. There is nothing for them to do at all. There is no strings attached. There is no tax consequences, but they just simply get a letter. It's like, winning the lottery without buying a lottery ticket. They just get notified that the debt has been removed and will be removed forever. And if it was put on a credit report, we would ensure that gets removed. Next slide. So to date, we're very proud to have been able to get rid of $12 billion with a B dollars of medical debt across the country, helping nearly 8 million families in all 50 states. So that just gives you, over the last 10 years of our existence, that's what we've been able to accomplish using this model. So next. So medical debt, yes, is extremely pervasive. I thought it would be important to spend a minute sort of talking about the issue of medical debt, and I'll have 2 slides focused on this. So it impacts 100 million people. 1 in 4 people struggle with medical bills. On the right, you'll see kind of where these medical bills or where the medical debts sort of sit with people. They owe the money to a family, a friend. You know, they're paying the provider over time. It's on a credit card, et cetera. And then on the left, you'll see like, what are the average debts people have? You know, there's $220 billion of medical debt out there. And that's just an estimate. And a lot of people think that might actually be low because, for example, if it's on a credit card, it's not considered medical debt. So it's really, there could actually be higher numbers of actual medical debt. But, you know, it's interesting. So 71% of the people, you know, have a medical debt that's $10,000 or more. But interestingly, 25% of people, which is pretty high, I think, have a debt that's under $10,000. And that shows you that this issue is not just one of the way we finance healthcare, but also an economic problem. People don't have savings to pay for these kinds of bills, right? And yet the expectation is that they have these high out-of-pocket costs in order to access care. Next slide. So medical debt is obviously a huge problem. It is different from other kinds of debts, and I think that that is being increasingly recognized. I'm very excited, and I think I saw quickly a little thing in the chat about the recent news that the CFPB just announced. We were very excited earlier this week that they are proposing that medical debts not be part of credit reports. And I think that that's huge. There are other impacts of medical debt, obviously, on individuals, but that is a recognition that medical debt does not indicate someone's credit worthiness. And so it is different, and it is recognized as different time and time again than other kinds of debts, because it is more of a trap for individuals. You need to get medical care. You don't have control necessarily of what your out-of-pocket costs are going to be. And lo and behold, you end up in medical debt. And that's why this last bullet really is the one that I like to highlight the most, which is getting sick. Getting sick, not your insurance status or being uninsured, is the biggest predictor of medical debt. It shows that we're all potentially very vulnerable to this problem. It is more prevalent in communities of color, like so many other things in the United States. It is the leading cause of bankruptcy, and it is itself a social determinant of health, which is very telling. You know, people just don't have the money to buffer the shocks of medical debt, and they increasingly avoid getting care because of medical debts. And it does feel like a real mental health burden. And the amount of anxiety people feel around this issue is palpable. And so unfortunately, you know, I'm very proud of the work that we've done and the attention that our organization is getting. But I think it's because of the fact that this is such a common and increasingly common experience for people, and that I'm not so proud of. So next slide, please. So one of the pieces of our, I don't think we're going to show this video, but we'll follow up and share it with all of you. One of the things that we're really intentional about at Undue Medical Debt is to tell the stories of the people that we're helping. So we recognize, as I said earlier, that our work has limitations, right? That it's important, and we're doing what we can from where we sit. But it's important that we tell this story of medical debt in a more comprehensive way and push for larger changes and upstream solutions. So we have anthropologists on our team and a department that's focused on telling those stories of the individuals so that we reduce the stigma associated with medical debt, and we illuminate the sort of value of focusing on this issue and doing something about the problems. And we hope that this informs policy priorities and solutions. And I'm going to share with you a couple of the stories so you can see some of the themes we hear from people. So go to the next slide, Gregory, please. So this is someone that we helped in Illinois. We got rid of $2,000, a little over $2,000 of her debt. You know, obviously she was shocked by the letter and excited about it. And, you know, she says, a weight has been lifted, and I am so grateful. Around the time that I accrued this debt, we were about to enter into the COVID-19 pandemic. I was working, but only making enough money to pay my main bills and buy food. Going to the hospital was the last thing I wanted to do then, because of the fear I felt about receiving yet another bill. And so you can see how people delay the care, but also the mental health piece in this, right? The anxiety and the angst about going to get care. You know, we hear stories about people sitting in parking lots of hospitals waiting to see if the pain subsides. That is not okay. And again, it's unique to this country. Go to the next slide, please. This is Dustin in Tennessee. For him, we abolished nearly $13,000, and you know, he thought he'd never get this paid off, and it was, you know, because of a medical debt that he had. He had a heart attack while uninsured. Next slide. Here we have somebody in South Carolina who we abolished just under $1,000. But again, you see, she didn't have enough to pay this bill. And, you know, you see her and her lovely daughter there. She says, "Thank you, Undue Medical Debt, for paying off my medical debt. I've been struggling to fix my credit, which has caused me to be in a depressed state." Again, the anxiety people feel. So when I received my undue letter, I was brought to tears. A common theme we often hear too, that people cry over this relief. I am thankful and grateful for this blessing. So you can see that this is, again, a common theme. And then this is the last one I'll share. Next slide. This is a woman from Boca Raton, Florida. Again, her and her child, and this one has to do with pregnancy. She says, "Wow, I have been stressing about this medical debt for 3 years. Most I accrued from an unforeseen complications related to my pregnancy." Again, very common. This was a life-changing event. Afterwards came a grueling period of financial recovery and turmoil that lingers. Thank you so much for removing this burden and helping me get closer to my goal of financial stability. You know, I think that this for me is a real killer. Women having children and then being almost set up for failure. You should be set up for such success. And we have so many programs out there trying to help people do well when they first become parents. And yet we set up systems like this that undermine those goals. It doesn't make a lot of sense. Okay, next slide. So yeah, this I just wanted to point out, this is the connection of the work that I was talking about. You know, we recognize that what we do is very downstream. There's midstream solutions and there's upstream solutions. You know, midstream solutions are things like working with people to get, you know, on their finances, getting them financial counseling, things like that. More upstream solutions are ensuring that people have better health insurance access, right? That they're actually insured, that we have good financial assistance policies in place at hospitals and require those. So we're working and firing on all cylinders to connect the dots. So we do what we can from where we sit, but we also make sure that we are leaning into upstream and midstream solutions. And that's why we work with great groups like DuPage Health Coalition to make sure we recognize that we don't need to be or want to be in every community and steeped in it, but we want to partner with those who are already there doing the work and doing midstream and upstream solutions, leaving something, as I say, in our wake. So let's have local entities work with us in collaboration and get the issue and the hard work of medical debt addressed locally. Different places, different solutions will work. And so we are not experts in every community on what works, but we are experts on relieving medical debts and can bring that to communities and pair that through these collaborations. And that's exactly what we're doing here in DuPage, and are excited to be working with Kara and her team. And then next slide. I did want to mention that right next door, we're working with Cook County. They were the first ones to come to us and asked if they could use the federal ARPA funds, American Rescue Plan funds, to relieve medical debt. And we had a long conversation, many conversations, and they ended up appropriating $12 million towards us to get rid of $1 billion of medical debt. To date, we've gotten rid of $400 million and have helped 200,000 Cook County residents. And this brings me to how our model works a little bit more. So when we work with a hospital, you know, hospitals don't follow the same borders. So we're working with Cook County hospitals. They will have people in those portfolios that are in DuPage, right? And vice versa. We could work with a hospital that's based in DuPage but has Cook County residents. So what we do at Undue is we pair the dollars that come from certain places to focus on the residents. So in Cook County, when we get a hospital portfolio, we don't want to leave the people that are not living in Cook County out of the debt relief. We just want to find find a different funding source for those people because Cook County won't allow us to use those funds, right? So that's why we have to do things like this and fundraise for specific places, right? It just shows you how our model works in terms of ensuring that we get everyone at the table and that we use a variety of funding sources to get rid of these medical debts. So if you could go to the next slide, Gregory. So in this particular example, as I was mentioning earlier, we are trying to fundraise $100,000 to abolish $12.3 million of debt to help over 10,000 DuPage County residents. And we hope that we can successfully do that through this effort. So those are my slides.
Thank you so much, Allison. I will pass it now to Kara. Kara, if you can come off mute and you can take it away.
Excellent. Good morning, everybody. It's really exciting. This is sort of, in many ways, a culmination of almost 2 years of partnership with Undue and our partners, formerly RIP. And it's been an outstanding partnership for us. We've learned so much, and it really fits perfectly into the mission of the DuPage Health Coalition. I'm the president of the DuPage Health Coalition. We're a local organization in place since 2001, coordinating comprehensive health access for low-income, uninsured, and underinsured residents of DuPage County. Next slide, please, Gregory. Speaking very briefly, I could talk for hours on this topic and certainly will not. What we do at the Health Coalition and what we believe, first and most importantly, we believe that every member of our community deserves unfettered, comprehensive access to high quality health care. And we also believe that that is within our reach, that we have the capacity through partnerships, through resources, and through innovation to create efficient and effective pathways to healthcare. We believe that every resident of DuPage County can have access to comprehensive, high-quality healthcare. But we also recognize that medical debt is both a substantial challenge for those families that we serve and a threat to people being able to get the healthcare that they need and deserve. The patients that we most commonly serve at the Health Coalition are either uninsured or underinsured. We have different programs that are targeted at supporting people in getting the best health insurance they qualify for, and other programs that are available to help people who don't qualify for or have a pathway to health insurance. We primarily focus on individuals that are at or below 2.5 times the federal poverty level, which is one of the reasons why it's really great for us to be partnering with Undue, because we recognize that someone that has income that's a little higher than those that we can commonly serve still has significant unmet health needs. And Undue's partnership gives us pathways to be able to provide some assistance to a more generous network of our community residents. You know, people think of DuPage County as a largely affluent community, and that's a fair characterization in median income. But we have hundreds of thousands of low-income residents in our community. It's the second most populous county in Illinois. And that means that even though our median income may be relatively high, there are many, many folks that are struggling with food insecurity, with housing instability, and with a state of insurance, either uninsured or underinsured, that renders them unable to get the health care that they need. Practically speaking, the folks that we serve through our Access DuPage program, which coordinates access for people who are uninsured, is largely immigrants, because those are the folks who most commonly don't have a pathway to be able to get comprehensive, high-quality health insurance in our current system. And we've served, actually, that statistic is a little bit old, we've served more than 70,000 patients with our Access DuPage program since we began. All of the work that we do, however, is only possible because of partnerships. We depend on our healthcare partners to donate or provide low-cost access to many of the services that we provide. And we also depend on partners who provide us funding that enables us to do the work that we do. But we know that people invest in what they help to create, and this is really a program that is driven by and co-created by all of our partners here in DuPage County. And we believe that when we do our work well, it's possible to create true health equity for our patients. And we can do so without creating, no pun intended, an undue burden on our healthcare system, because if everyone actually contributes proportionally to being a voice for change and progress, it's not actually an overwhelming task for any one of us. Next slide, please. These are just a smattering of the different kinds of programs that we offer here at DuPage Health Coalition. I'm not going to talk about most of those programs. Again, not the topic for today, but it's to recognize that what we really need is to have a network of services that are intended to create meaningful solutions to some of the intractable healthcare challenges that we're all facing. And really, our portfolio of programs is intended to look at the system as it currently exists, much like Undue does, and find meaningful, effective solutions to solve for today's challenges, recognizing that we ultimately are working for a fundamental reordering of that system so that some of those challenges are no longer prevalent in the future. I will highlight that the programs that we're probably most known for, Access DuPage is the program that I've mentioned already that's provided care for so many thousands of our local residents. But we also have a program called Silver Access, which helps people to purchase the health insurance for which they qualify. And our goal in that program is to make sure that people have access to high quality, comprehensive, low out-of-pocket coverage. As Allison said, the biggest predictor of being in medical debt is being sick. And unfortunately, and especially for low-income families, but really for any one of us, if you have health insurance, but it doesn't offer you meaningful access to low-cost care, then that is going to greatly exacerbate the likelihood that you have outstanding medical debts. You may be insured, but that insurance may not confer enough coverage to keep you out of debt. And so that's a piece of the work that we're doing. Next slide, please, Chris. I want to take a moment to acknowledge our partners, because I think it's probably the fact that we had such deep and enduring partnerships that made this partnership with Undue a good fit. Since our program began back in 2001, we have enjoyed and been able to do the work we do as a consequence of all of the partners whose names you see on this slide. We have a budget of about $4.5 million a year at DuPage Health Coalition, but our patients are receiving more than $40 million worth of donated care as a consequence of those partners. And so we've really developed these close relationships. We are, mutually synergistic relationships between the Health Coalition and those hospitals, those large medical groups, those FQHC providers. And it really created a fertile ground for us to be able to have those conversations around medical debt and to be able to think thoughtfully and collaboratively about how we might partner to make that medical debt abolishment a reality here in DuPage County. Next slide, please. So, an admission, and the admission is, as I've said, we've been doing this work for more than 20 years, and we weren't naive. We recognized that we probably had some patients who were continuing to struggle with debt, either debts that may have been accrued before they came to be enrolled in our programs, household debts that perhaps were for people that weren't enrolled in our programs, but related to others who were, or maybe services that they had received that were sort of outside the purview of our programs and services. But we wanted to ask the question, and back in spring of 22, we did in fact ask the question of all of our members to understand what their debt story was. And we were disheartened, if I'm honest, by the data that you see in front of you. The situation was worse and more critical than we had realized. And it was really understanding just how much debt our patients, even with all of the generous services we provided, were still living with, that compelled us to reach out to our partners at Undue and try to create this relationship, respond to an offer that they had put forward and say, please, please, can we be one of the partners for this initiative? Because what you can see there is that despite the programs and services, when we surveyed our members, we got a strong response to our outreach. And in fact, we saw that 35% of our patients had debts in their, 35% of those who responded to the survey indicated that they had debts that were greater than $5,000. At the income levels that we are serving, there is no chance that those folks have $5,000 of disposable income to be able to pay down a debt of that size. 62% of the people who responded indicated that their households had medical debt. So you heard Allison say that 1 in 4, which is itself an unacceptable number of United States residents have debt, but our numbers were significantly higher. And you can also see that the debt is coming from a variety of sources. Hospitals and emergency rooms do comprise a significant portion of the debt, but it's also doctors' offices and ambulances and other healthcare providers. Next slide, please. With that in mind, we sort of took two-pronged approaches to this project. And one piece is the piece that we're lifting up today, our partnership with Undue. We reached out to all of our health system partners, have actually been in conversation with a number of health partners. We're going to talk about one who's a bit further along in their debt abolishment journey. Today, we're very excited that our partners at UChicago Advent Health Hospitals have worked through an agreement to ultimately result in debt abolishment for $51 million, again, with more than 12 million of that representing DuPage County residents. And as you might imagine, when we got that news, that was something that we were celebrating, both for the thousands and thousands of patients that were going to be positively benefited, and for the fact that it felt like we were seeing a really a local response that we thought might be able to grow in momentum and steam over time. Next slide, please. In addition to our project with Undue Medical Debt that ultimately resulted in that agreement for future loan abolishment, debt abolishment, we also launched a new initiative here in DuPage County, which continues today. And I want to acknowledge that it's partnerships with Endeavor Health and the Retirement Research Foundation that makes this arm of our project possible. Medical Debt Care DuPage was a project that we launched because we recognized that a couple of things were true. Number one, we had health partners who were willing, able, and in fact, encouraging of debt abolishment and debt relief for many of the patients who had bad debt at their hospitals. They had generous financial assistance policies going up to 600% of federal poverty. They would provide either total write-off or significant discounts for people who had medical bills that had not been paid. But what we were really learning is 100% of our patients qualified for those programs, and yet we had 62% of our patients that still said that they had medical debt. And that suggested that there was some sort of gap or misalignment between the programs as they existed and our patients' ability to access them effectively. And what our program does, we don't pay medical debt, but we help people to apply for the existing programs and resources that are already available in the community. And I think it's just an elegant bookend. Undue is handling things at a macro level, addressing debt for thousands of people at one time, which is incredible. But we don't have that capacity without that partnership. What we have the ability to do is work one-on-one with individual families, looking at both those debts that may be at health systems, but also at individual medical provider offices or ambulances and all of those other pieces and parts. It doesn't matter to us whether someone has insurance or not. It doesn't matter to us what their income is, and it doesn't matter to us what their immigration status is. If they have a debt, we're more than willing to screen them to see if there might be assistance available, help them to apply for that existing assistance, and then also help them to better understand how to navigate that process should the circumstances occur again in the future. Also excited to announce that we have a special partnership with DuPage County and again, Retirement Research Foundation that will be launching this summer that will specifically focus on the needs of older adults who are living with debt burden, either their own or other members of their family. So this project continues. We actually have funding for the next 3 years to support this program through our network of partners. Next slide, please. I think it's actually the last slide. So I can share that over the course of the 24 months that we've been working on Medical Debt Care DuPage, in addition to the $51 million in debt relief, almost 13 million of which is DuPage County focused, that we've partnered to prospectively see here in DuPage County, but we also have $14 million of additional debt relief that has come through the Medical Debt Care DuPage program. That has impacted 1,500 local DuPage County residents, 4,400, I'm rounding here, bills or claims. It's also worked at the policy level to understand better why it is that patients are struggling to navigate those existing systems and putting new systems in place in partnership with our health systems to be able to make it easier and better for patients when they encounter bills that they need assistance paying. And as I said, thankfully, we have funding that allows us to know that we'll be able to continue to do this for the next 3 years. And those, I think, are my slides.
Thank you so much, Kara.
Thank you.
And thank you all for, so there's a few questions I've received. 2 are logistically, so I just want to pose that. So we're going to take about the next 10 to 15 minutes for any discussion that's coming out of the presentations or any questions generally. And I'm wondering, Allison, if you could address we had brought up the announcement with CFPB, and we linked to Undue's response on that. But if you could just acknowledge and mention where we're at with that and the impact of that. And then also there's just a question logistically about how we source patients, regarding about how we target patients. And I think, Allison, if you could just provide some insight on the ways we do and do not control what patients we have access to, like regarding demographics or like patient type. And then there's a few other questions that I'll field, but I just wanted to start with those if that makes sense. Thank you.
That's perfect. So great questions. So on the CFPB, I mean, we couldn't be more excited that this has happened. It's been a long time coming. We've had a sense that this might be coming, given some, discussions and questions we've been having with CFPB when they, we've commented on this and pointed out that medical debts are different from other kinds of debts. And so it's really meaningful. We're very excited. I do still think that the reality is medical debts often are in other places. Unfortunately, people do put them on credit cards, which then unfortunately don't make them medical debts. So those will still show up. And there are a fair number, believe it or not all medical debts are put on credit reports. In fact, a lot of hospitals do not put medical debts on credit reports. So it is not, while this is huge and it really helps a lot of individuals, there's plenty of people that have medical debt that this won't impact because they would have never been on their credit report in the first place. And I think it's a misconception that that's the only impact of medical debt. There's bigger implications. The credit report is one piece, but there's still, this is why one of our policy platforms is to say there shouldn't be extraordinary collection action that's allowed. For example, they could still garnish your wages, go after your home, things like that. Now, in different places, that's not allowed. There's increasingly legislation, which we're supportive of, that's banned those kinds of actions to collect on medical debt. But then there's also, there's that financial piece. But honestly, what we hear from the individuals we help is there's shame involved in having medical debt. And it weighs on people in ways that I think we need to further study and appreciate. But from what we hear back from the beneficiaries that we help, it makes them think twice about going back to the doctor or getting the care that they need. They ration their care. They try to ignore some of the pains that they're feeling. And it's just mentally draining for them, which again is connected to your physical health. So I think there are other implications of medical debt beyond the credit report, but overall, I would say, it is important to take it off of credit reports. And I think it's a recognition that medical debt is different than other kinds of debt. So we are very excited about that. The next question, Gregory, was about how we target patients. So we were pretty much blind to any other feature except for the person's qualification. Like I said before, when we work with a hospital system, we get the entire bad debt portfolio, and we analyze it just looking at 2 qualification criteria. Anyone that's medical that is 400% of poverty or below, or if so they could be over 400% of poverty or below. if the debt is 5% or more of their income, we will eliminate that debt. So those tend to be larger debts, obviously. So that's it. And we will not, as I said earlier, we're very intentional about raising funds so that we can make sure that we don't just focus. So for example, like I said before, with Cook County, if it's a Cook County focused hospital, if there's people within that portfolio that are not in Cook County and we can't use Cook County dollars, we're looking to fundraise, and we always do that. So we never leave anybody out otherwise. So we really don't have like a targeting of patients, if you will.
Thank you.
I just want to add, if I could, on the topic of sort of the pervasive challenges of medical debt, and absolutely celebrating, actually, a colleague forwarded me a Kaiser story about Biden's recommendations around credit reports this morning, and I was cheering. But I would note that article also continued to promote and advance states and local municipalities and other efforts to purchase and abolish medical debt, as Kamala Harris was actually quoted in the article, acknowledging that continued to be an important piece of the puzzle. But when I think about medical debt and its pervasive impacts, there's another piece that we oftentimes don't think about, that isn't in fact the person that is in debt, but the person that is making decisions to avoid debt. So we tend to focus on those individuals who've been unable to avoid that debt that is now sitting on their reports. But the fear of debt changes everyone's healthcare behaviors. And sometimes they are successful at not seeking that care that they need. And so they don't show up on the bills, but they didn't get the care that they needed because our system places people in a circumstance where they're more afraid of the debt than they are the disease. So they don't get the screening. They don't go to the primary care provider for the visit that they need. They don't get the colonoscopy. And then they end up with the consequences of delayed and deferred care down the road. And I don't think our debt picture accurately takes on that element of it, but it's really just as large and significant as the other side. Those folks are struggling with the debt already that they've accrued.
Thank you so much, Kara. There's one question I'm gonna pose and then another question that kind of bolsters it as well. But in the chat, there's the question, is Undue planning to scale this model of partnering with a local coalition to gain access relations with local health systems? What would it take to do this? So if you all could just react to just the partnership and the ways that it's led to hospital relations. And then another question, which is a little more pointed, is how does a hospital sign up? So I think, I think that's two sides of the same coin. So Allison and Kara, if you could just, you could indulge that'd be great.
Well, first I'll just say, how do you sign up? Like, just call us, go to our website. There's a place where you can fill out a form. Like, we make it very easy. It is not hard for a hospital to sign up. We are looking for hospitals all across the country and other providers. So please encourage hospitals to sign up. And I of course will let Kara jump in here about, why she partners with us, but we absolutely want to scale this. We do have other examples of places where we have relationships like this. I mean, I think at the end of the day, it really lends a lot of credibility to us, right? I mean, we recognize that Kara's got a lot of street cred, and we're not looking to like start from ground zero. We want to get this ball rolling, right? So I want to establish a strong relationship with someone like Kara, who is, out there. She has these relationships, and again, she's pairing it with something that's bigger than us, and we want to do more and more of that. And so that's actually Gregory's whole job. We hired him specifically to help us do this. And it started, Kara was part of our sort of initial great experiment on this front, and we're still leaning into it. But, we've learned a lot. And yeah, we're absolutely know that this is a winning strategy. And we're going to keep doing this in different places. So Kara, please feel free to jump in.
Yeah, so I'll just share by way of background for folks who sort of wonder how we started dating. That a little bit about 2 years ago, the DuPage Health Coalition is a proud member of a national organization of nonprofit donated and safety net healthcare providers called Communities Joined in Action. And Communities Joined in Action all of us are committed to 100% access to healthcare, zero health disparities. And so Undue, recognizing that CJA's mission and their own aligned so nicely, had actually reached out to CJA as a potential pathway to getting to know organizations that might be a good fit for this community engagement work. And so we participated in a webinar, and even back 2 years ago, it's only become more true today, that the topic of medical debt and the painful consequences of medical debt was really getting a lot of attention. And we were having internal conversations about whether or not we could do more or should do more to address it locally. And so when we learned that this webinar was being hosted, we joined up. I tell RIP Undue all the time that we are pretty sure we stalked them, because we were literally sending direct messages during the webinar. I think we followed up with an email afterwards. I think that, because we really were so excited about the opportunity, and we did believe that we had the partnerships here in DuPage County that would allow their vision for how this might work to be successful. We are so grateful for 2 decades worth of partnership with all of our health system partners. And there is something that you cannot buy and you cannot easily co-create that comes with decades of working together on a shared goal. And what it means is that if we have a conversation at the DuPage Health Coalition board meeting with all of our health system partners and we talk about this topic, this is a difficult topic for health partners. And I completely understand why it is, because oftentimes they are demonized as though they were at fault for some of the frailties and flaws of our health system, when in fact, from their perspective, they're doing an awful lot of work that isn't always as successful as they would like it to be, to identify people who should not have these debts. And so this gave us a way to be able to take their sincere interest and actually add some energy, momentum, new resources to the puzzle. And our partners have been very, very responsive to that, willing to have those conversations, willing to think critically about whether or not there are other things that they can do within the walls of their health systems to make this work better. Be willing to be great partners to us on these one-on-one efforts to abolish debt. And then in a number of cases, and we hope more to come, willing to partner also with Undue on these large-scale debt abolishment efforts. So it's, we thought we would be a good partner, and it feels like we are a good partner. I would imagine there are others like us in other communities, and it's really a question of the right matchmaking to find the places where it can work well.
Thank you so much. There's a question that kind of blends with this great. It's just regarding what motivates hospitals to deal with, to work with Undue and partner with us versus dealing with collection agencies to collect on medical debts. And I think to expand that, if we could just discuss on what we've learned about why hospitals like to work on these initiatives and how we've garnered their buy-in and the benefits of that versus obviously putting to collections and et cetera.
I mean, I can start, and Kara, obviously you have direct experience as well. I mean, but at the end of the day, my experience is the hospitals the people who qualify for our program are people who would struggle to pay the bills. I mean, that's it, right? If you're at 400% of poverty or below, like the bill is probably a financial burden on you. I mean, that checks out when we look at the portfolios of bad debts that we end up abolishing. People are struggling to pay. They just don't have the means. There's unreasonable expectations of out of pocket. And that's, in large part, I think, because of our failures of our insurance system too. I mean, people walk in the door with deductibles that just, when they don't have savings to meet those deductibles, like there's really a big problem. And I think that this problem does fall at the feet of the providers oftentimes. And the patient's caught in the middle, right? And I think providers there's always shifts also in the healthcare system. And there's always ways that we're trying to plug holes and make changes and, get people signed up for insurance. But, you change jobs, you fall through the crack, your employer often is changing your health insurance. You don't remember if you're in network, out of network, emergencies happen. You don't know who's caring for you if they're in network. And there's so many potential pitfalls to getting healthcare. And I think this problem falls in the laps of providers largely, and they recognize that it's a problem. And honestly, increasingly the clinicians, the doctors, they're pissed off too. And they're, saying to the administrations of the hospitals they work for, hey, this isn't working for me. I go to, treat a patient and they're yelling at me like, what is this going to cost me? And I don't want them to be focused on that. That's a difficult, frustrating, uncomfortable place for me to be when I'm trying to help someone and provide my services as a doctor or as a nurse to make the person, better when they're in need, and they're focused on what's it's going to cost me. So this I think is very aligned with actually where hospitals are at. And so they work with us because they recognize that this provides them with a way of addressing a problem that they can't solve by themselves.
I would just add that when we're talking of, there is a natural, understandable, and irreconcilable tension between having the mission to provide care for patients and then being in a position where you're trying to collect funds from someone that doesn't happen. And so my experience is that when providers and partners are presented with pathways to be able to resolve some of that tension, they're commonly enthusiastic about the prospect, because on one hand, my goal is to take care of you and make you better. And on the other hand, we have this transaction that makes that more difficult. But at the end of the day, we also have a health enterprise that is contingent on those transactions. And so until we figure out a different system, and I don't think that I'm going to hold my breath on that one in the next couple of years, we have to find some really effective ways to look at some of the root causes. The other thing that I'll say, and it's a quote from the partners with whom we were working on this particular project, they were not fundamentally motivated by the funds that were going to potentially change hands. The amount of dollars that will change hands through this transaction, while meaningful, are relatively modest relative to the budgets of the hospitals that we're speaking about. When I asked them why they were enthusiastic about doing it, the answer was because it's the right thing to do, and this is a good way to do it. So it felt good for that health system to be able to know that those thousands and thousands of patients were going to get some very good news and hopefully feel more comfortable about getting the care that they needed as time went on. And I think that that's probably the most important driver of all.
Thank you so much. There's a few more questions, but I want to be cognizant of time. The one question that this kind of is bigger, but it just asked, do we help people that are insured? And that's a much bigger conversation, but because common sense would make you think otherwise about medical debt. So I included a link just about the ways that people who are insured. So the short answer is yes, anyone under the qualification, insured or not, can receive debt relief. But I want to give Allison and Kara to just any opportunity to speak on the role of insurance in this. And then one other question, not fully related, but I just want to close out the call with good time, is the role that ARPA funds have played. So how much will the ending of the ARPA funds affect Undue's revenue sources? And so I just that's a great question and a great opportunity. So if you all just want to touch on the role of insurance in this, which is much bigger, but just high level, and then just speak to the ARPA funds and the different sources that we have coming. That would be great. Thank you so much.
Sure. Let me recognizing time. So on insurance, and I'll let Kara, of course, add to this too, but on insurance, a lot of the people, most I would say of the people we help actually are insured. I mean, 90+% of people are insured these days. They're underinsured. So what we're relieving oftentimes are their deductibles or their out of network, costs. So things like that. So it's not about insurance status. In terms of the funding, rest assured, we are going to be doing fine post ARPA. In fact, a lot of our funds, when this is very intentional by us, come from private sources. They come from individual, a lot come from individual donors. The thing I love about our model is it lets anyone be a philanthropist. People, do localized campaigns, and we have about 150 that run per year there, where they, set up a campaign for their local community, their state, et cetera, and they raise funds you know, and that's like $15,000 and up that people run, as well as, you know, people that have higher incomes do make large donations to us. You know, I think local governments, while ARPA funds have been the impetus for this, I think they're increasingly recognizing that they can use other government funds as well. So we also have seen governments use general tax revenue to support us. So I think we'll be fine in terms of our revenue going forward. I have no qualms or worries about that.
The only thing that I would add is that something that we haven't talked about, and it speaks in part to the insurance side, but also more broadly to the reason why for the DuPage Health Coalition, this is such an exciting project. As we think about those letters going out to 10,000 DuPage County residents who were struggling to be able to pay for the health care that they needed, one of the things that I am most enthusiastic about is the opportunity to use that communication to also alert people to the availability of other resources that are local here in the community. So the letter is going to be sent, but ultimately once the fundraising occurs, that, you know, ensures to them that they have in fact had that initial debt abolished. But then subsequent to that, we want to help make sure that they're linked up to all of the tools and resources that are available here through our programs and other community programs, so that they can get comprehensive, efficient, effective, high quality care in the way that befits our mission and the goals of the Health Coalition. So that is some of the downstream consequences of this partnership that I'm most excited about. People that probably never would have heard about or didn't know that those resources were available, and I want them to know.
Thank you so much. Karen, Allison, I'm gonna close out the call. We're up at time. I thank you all so much for all the questions and the engagement from the audience and the attendees. I just all the follow-up will be sent in email, and we'll be including the slides as well. Someone asked, and I appreciate that. So, and we'll also be including all the information on donating towards our campaign to raise $100,000. Which again is going to alleviate $12 million of medical debt in DuPage County alone. So please reach out in the interim. Thank you all so much for your time today.
Thank you.
Have a great day, all.
Take care.